Assalamu alaikum. It's a great pleasure to be here today in Lahore once again. Always a pleasure. Thank you very much for the invite and invitation. The topic that I have been given today is lupus nephritis. So I'll start with this brief case history of a 13-year-old girl who was referred to us back in 2018. She was anemic. She had dropping hemoglobins at that time. At the same time, some mood changes, aggression, and psychotic sort of episodes. In the past also, she had autoimmune hemolytic anemia in 2016, and as expected, she was given some oral steroids, iron supplements, and some blood transfusions as well, but unfortunately, she got hepatitis B positive as a result of those repeated transfusions. When we saw her, she was anemic. She had some oral and nasal ulcers. Rest of the examination was essentially unremarkable at that time. She was anemic with hemoglobin of 7.6, white cell count of 8,000, platelets normal, ALT, urea, creatinine were fine. Her ESR was raised at 95. Urine at that time was clear, and she was hepatitis B surface antigen positive through ELISA and PCR. She was strongly positive ANA with strongly positive anti-double stranded DNA antibody with low complements and a direct Coombs test positive suggesting hemolytic anemia. Due to her neurological symptoms, we did an MRI of the brain, which was normal. During the admission, she developed seizures, and despite a normal MRI scan 2 weeks ago, she still went into those epileptic sort of episodes. And therefore, we requested a repeat MRI, which suggested that there were some bilateral white matter changes suggestive of vasculitis or neuropsychiatric lupus. In consultation with the neurologist and hematologist, she was started on IV methylprednisolone. She was given IV cyclophosphamide and some Epivol. She was commenced on hydroxychloroquine, and for hepatitis B, Ecavir, and also prophylactic Clexane. She deteriorated further after receiving IV cyclophosphamide and was transferred to the intensive care unit. Her cultures were negative back then. And after discussion with the neurologist, since she was not tolerating the cyclophosphamide so well, she was commenced on mycophenolate, mofetil, at a dose of 360 milligrams 3 times daily. But at the same time, we also started her on plasmapheresis. She responded to the plasmapheresis and MMF. However, the plasmapheresis had to be stopped due to infection of her central line. And then she was commenced on IV meropenem. And because she had active lupus at that time and with the hemolytic anemia, we thought it's a better idea to give her some IV immunoglobulins, to which she responded really well. The seizures settled as well. 5 days later, she was shifted to the ward and was doing well. She remained on mycophenolate for a couple of years, but then she presented with bilateral periorbital edema and rising blood pressure. At that time, she had proteinuria, she had red blood cells in her urine, and her 24 hours urinary protein was almost 2,800 in 24 hours. We did a renal biopsy which suggested class 4-5 lupus nephritis. And this happened in spite of she being on mycophenolate. The mycophenolate dose was cautiously increased to full therapeutic dose, and she was started on tacrolimus as well with SE inhibitors. She responded to the treatment, to the combination treatment, and the proteinuria improved to less than 1 gram in 5 months. However, in March 2021, she developed tacrolimus-induced red cell aplasia. This was ultimately stopped, and rituximab was planned. She had 2 doses of rituximab, but apparently she did not respond so well. She continued to have anemia. I recently saw her and increased her myfortic, but she was not able to tolerate it so well and had some loose motions with it. Therefore, the dose was reduced again. She continues on delta-cortical 10 milligrams once a day, and this is always a challenge. Whenever I see her, I find it quite difficult to reduce her steroids, and on and off I've been giving her higher doses of delta-cortrel. But we are aware that delta-cortrel in lupus has its own hazards, and the long-term issues in terms of infections and outcomes is not great if we use the steroids, of course, in higher doses every now and again. Her blood pressure recently was raised, and we just added some beta blocker to the existing ARB and diuretic combination. So in summary, this lady, young lady, she's now 17, 18 years of age. She has lupus nephritis, neuropsychiatric SLE, autoimmune hemolytic anemia, and vasculitis. And so far, she has had IV cyclophosphamide, plasmapheresis, IV immunoglobulins, rituximab, mycophenolate, tacrolimus, IV methylprednisolone, and quite a long courses of steroids, although she remains on 15 or 10 or 7.5, but rarely on 5 milligrams and less of delta-cortrel. So I've been following her up for the last few years, and this talk today is really important from the point of view that in rheumatology we come across these complicated cases. Lupus nephritis is one of these conditions which is most frequently seen and has got serious complications in SLE. It typically develops in the first 5 years after SLE diagnosis. Histologically evident in most patients with SLE, even those without clinical manifestations of renal disease, 3 times increased risk of death. So this is quite important to be aware of, that we need to look after these patients and try to diagnose their nephritic element as soon as we can. 30% of patients will develop end-stage renal disease or chronic kidney disease. The pathophysiology is a bit complex and not go into the details of this slide, but definitely B cells, T cells, and dendritic cells trigger plasma cells, T helper cells, macrophages, and then the cytokines are produced, causing lupus nephritis. The presentation of lupus nephritis can be asymptomatic. They can have peripheral edema due to fluid overload, and symptoms due to hypertension such as headaches, dizziness, visual disturbances, cardiac complications can be experienced by these patients. Symptoms due to active SLE, fatigue, fever, rash, arthritis, serositis, etc., or oral ulcerations or hair loss, etc., may be there as well. Investigations as routine. We'll do all the baseline investigations, inflammatory markers, but the most important thing is to have a look at their dipstick as well. And there should be a low threshold for checking their 24 hours urinary protein. Likewise, the usual complements, double-stranded DNA, and inflammatory markers. But there are some new investigations as well, and these need to be kept in mind. At the same time, alpha-1 acid glycoprotein, ceruloplasmins, lipocalin like prostaglandin desynthase, and transferrin, etc., are also important to be aware of. The renal biopsy is the most important investigation here, and under appropriate conditions, renal biopsy should be performed promptly within days to weeks. Biopsy is useful in establishing the diagnosis. It determines the class and helps us deciding about the management plan as well. The renal biopsy should be considered when there is evidence of kidney involvement, especially in the presence of persistent proteinuria more than 0.5 gram in 24 hours, or urinary protein creatinine ratio of more than 500 in the morning first void urine, and or unexplained decrease in the eGFR. So you all are aware of these 5-6 classes of lupus nephritis. According to the International Society of Nephrology, class 1 will have minimal mesangial lupus nephritis, class 2 will have mesangial proliferative element, and then the focal lupus nephritis, diffuse, and then the membranous and advanced sclerosing lupus nephritis. And these are the different histopathological pictures. And then we need to be aware of the activity and chronicity index. So activity index mostly includes hypercellularity, leukocytic infiltration, hyaline deposits in the subendothelial space, fibrinoid necrosis, cellular crescents, and interstitial inflammation. However, chronicity reflects mostly about the sclerosing element, the fibrosing element, and the atrophy and interstitial fibrosis, which means that the process has been going on for a long time, and there is then subgrading of the activity and chronicity index. Apart from the classical lupus nephritis, we need to be aware that in lupus we can come across a thrombotic element of kidney involvement as well. We all know that a certain number of these patients can have antiphospholipid syndrome, and thromboembolism can be one of these factors as well. Then vasculitis, tubulointerstitial disease, and lupus podocytopathy is another thing that we need to be aware of at the same time. So I just briefly will touch upon the lupus podocytopathy, which is the diffuse epithelial cell foot process effacement without immune complex deposition. This usually leads to nephrotic syndrome in comparison to nephritic situation that we come across in lupus nephritis. The normal glomeruli on light microscopy are usually seen, and there is absence of subepithelial or subendothelial deposition. This is a picture of the lupus podocytopathy. Then we have got the lupus-associated TTP. I'll not spend much time on this, but when it comes to management of lupus nephritis, the goals should be clear from the outset. So we need to think about remission induction, remission maintenance, prevention of damage accrual, and minimizing drug toxicity and improving quality of life. So remember that all patients with lupus nephritis, they need to be on hydroxychloroquine unless there is a very valid reason that you cannot start it for some reason, or for example, if somebody is allergic to this. But usually in class 2 lupus nephritis, you do not need much in the way of immunosuppressive medications, but we need to ensure that the histological reassessment in the presence of significant proteinuria is done well in time. When we talk about class 3, 4, 5, and beyond classes, among patients with class 3 and class 4 lupus nephritis, first-line options for induction treatment may include mycophenolate and low-dose intravenous cyclophosphamide in combination with glucocorticoids. The maintenance therapy is usually through azathioprine and mycophenolate. And then at the same time, as a holistic approach to these patients, you need to think about renin-angiotensin-aldosterone system blockers, vaccination of these patients, statin therapy based on QR risk 3 score, and prevention of osteoporosis and bone protection measures, and low-dose aspirin. As a rheumatologist, we normally focus on the treatment which is essential for the patients, but I think a holistic approach is more that we need to consider, and definitely prescribing aspirin to this patient is one of the things that we need to keep in mind. Then the periodic assessment with urinalysis to measure proteinuria, presence of glomerular hematuria, cellular counts, serum complements, and anti-double stranded DNA antibodies should be done. Although in my clinical practice, I usually do not measure anti-double stranded DNA every now and again. I think once the diagnosis has been established, the levels of anti-double stranded DNA does not matter much in terms of management. So, in terms of targets, the EULAR aims for partial clinical response would be 50% reduction in proteinuria by 6 months, but the target would be to have a complete clinical response, which means that the proteinuria should be less than 0.5 to 0.7 gram every 24 hours by 12 months. The Euro-Lupus trial suggests that remission is defined as less than 1 gram per day of proteinuria, and the Lupus Nephritis Collaborative Study Group says that proteinuria of less than 0.33 gram in 24 hours. So complete clinical response is what we need to target and aim for. Normalization of serum creatinine and serum creatinine of less than 1.2 milligram per deciliter. Reduction of urinary RBCs to less than 10 and absence of RBCs casts are the targets that we need to keep in our mind. Assessment of a patient to adherence, in terms of adherence to treatment and compliance, is something that we need to keep in mind. If the patient is refractory and the response is not as we are expecting, monitoring of therapeutic drug levels, repeat kidney biopsy in some cases, and switch from mycophenolate to cyclophosphamide. Just in regard to the kidney biopsy, if your patient has antiphospholipid syndrome, please be aware that renal biopsy may cause catastrophic bleeding in these patients. So not in every case, but if the patient is not responding and you are suspecting some other conditions such as different vasculitis, for example, but not antiphospholipid syndrome, then you can go for it. Switch from mycophenolate to cyclophosphamide is one of the things, but I'll come to that. And multi-target therapy should be kept in mind, and also consider rituximab. So this is a good slide. So on one hand, on the left side, you've got proliferative lupus nephritis, class 3 and class 4. And then on the right side, you have got membranous. So we basically switch and play around glucocorticoids, mycophenolate, calcineurin inhibitors, and cyclophosphamide, and then at the end we have got rituximab as well. So if your patient is not responding to the conventional mycophenolate corticosteroid regime, then certainly you can consider calcineurins. And if they are still not responding, then rituximab is one of the things, and in between you can give them cyclophosphamide as well. Likewise, for the membranous lupus nephritis, mycophenolate and glucocorticoids, if they're resistant, consider switching to cyclophosphamide. You can use both NIH and Eurolupus protocols, and likewise, in between, you can also consider tacrolimus and cyclosporin. But if they're still resistant, you can go for rituximab. These patients, as we said earlier on, may end up in having end-stage kidney disease, and renal transplantation is the preferred option, along with hemodialysis and continuous peritoneal dialysis. In pregnancy, prednisolone, azathioprine, calcineurin inhibitors are safe, including hydroxychloroquine, and the ladies of childbearing age can continue with their pregnancy and lactation with these medications. As a rheumatologist, we need to have a holistic approach to these patients. So apart from managing their joints and skin and kidneys, we need to think about their cardiovascular health. We need to think about infections, their reproductive health and osteoporosis, etc., all at the same time. So just briefly touching upon the landmark trials, in 1986, the historical NIH trial suggested that cytotoxic group did better, especially the IV cyclophosphamide, in comparison to the prednisolone alone group. Then in 1992, the Bupas et al. Study suggested that IV cyclophosphamide was superior and better than short courses of IV cyclophosphamide. Then further, Chan et al. Suggested that mycophenolate was as effective as cyclophosphamide, and the studies went on. And then the Eurolupus in 2002 suggested that the low-dose group of cyclophosphamide had similar outcomes in comparison to the high dose. This is, the different studies. Unfortunately, in lupus nephritis, the options are not too many as we see in rheumatoid arthritis or other conditions. In lupus in general has got limited treatment options, and lupus nephritis, of course, carries the same problem. But we have these belimumab, voclosporin, anifrolumab, other medications which are now approved by the FDA, and more molecules are on their way, hopefully, in the near future. Unfortunately, in Pakistan, we see that these medications are not readily available, even if they are approved by FDA or NICE in the UK, or if they are used in the European countries. When we get these molecules, it takes decades to start using them in our patients. So basically, the take-home message is that early diagnosis of lupus nephritis is the key to avoid complications and be vigilant in these patients to look for lupus nephritis. Frequently check their urine. Don't hesitate to request 24 hours urinary protein. Treat early and monitor for complications. The one thing that I didn't mention here, because these patients will suffer with aches and pains, and I've seen that a lot of the physicians will prescribe non-steroidal anti-inflammatories. I personally think that that is, that carries quite high risk of having an adverse effect on the kidneys if they are prone to have lupus nephritis on one hand, and then you give them non-steroidal anti-inflammatories that can cause more problems. I thank you very much.